I'm going to be talking about air pollution and asthma. It's well known for a number of years that air pollution, ozone and particles especially, make asthma worse across a whole variety of outcomes. The common wisdom, however, until relatively recently, was that air pollution exacerbates asthma, but it doesn't actually cause the disease. And that conclusion is based on studies that have looked at regional air pollution in communities and found generally no larger rates of asthma in more polluted than in less polluted communities. In the Southern California Children's Health Study, we've looked extensively at the effects of regional pollution of the sort that you see here on children's health. These are regulated pollutants, and there's a good framework for evaluating and controlling those exposures. Our observations have been consistent. We generally don't see increased rates of asthma across communities based on the level of regional air pollution. In recent years, we've gotten interested in the health effects of the sort of exposures that you might see from living near a major traffic corridor like this. This pollutant mixture is almost certainly different in composition than this. These are largely unregulated pollutants, and I think, as you'll see, that thinking of these as two separate pollutant mixtures fits quite well into the cumulative risk assessment paradigm. And emerging evidence indicates that near roadway air pollution that varies within community actually does cause asthma. I think we've been looking for the last 30 years at the wrong pollutant mixture, and I also think, as you'll see, I think that that history has gotten in the way of advancing our understanding of the role of air pollution in asthma and has limited our approach to risk assessment. So just briefly, I'll tell you a little bit about the Children's Health Study. I'll spend some time on the evidence for causal relationship of asthma with near roadway exposure, because I think that inference is key to the cumulative risk assessment that I'm going to show you from Southern California. I'll talk about the policy implications of the cumulative risks of near roadway and regional pollution, and some opportunities for assessment of the population burden of synergistic cumulative risks that other people have referred to if there's time. The Children's Health Study actually it's a total of 16 communities across Southern California. Communities were picked originally based on the mixture of regional pollutants and to represent the extremes of pollution in Southern California that are very similar to the extremes of criteria pollutants across the entire country. And the regional pollution is on a background of a dense network of roadways that allow us also to study the near roadway pollutant exposures. There have been six different cohorts in the Children's Health Study. Almost 15,000 children have participated, and starting in 1993, we recruited 4th, 7th, and 10th graders, followed them through to high school graduation, evaluating them every year. It was a new cohort in 1996, and the most recent cohort was recruited in kindergarten and first grade in 2002. They're still under follow-up. There have been a whole host of respiratory outcomes, biological intermediate markers of air pollution. We've looked at early markers for atherosclerotic heart disease in children, BMI growth, and obesity, and epigenetic marks. It's been a great resource, and today I'll be focusing on asthma. We've used what is commonly used in epidemiologic studies based on either a parent report of lifetime physician-diagnosed asthma at study entry that we've characterized based on age of diagnosis or onset of wheeze, and new onset over the course of follow-up. We've also characterized in sensitivity analyses based on a nurse practitioner interview with as many of the children and families that we could get through to improve the diagnosis, and in a subset we've looked at skin prick tests for allergy and exercise challenge for airway hyperreactivity. In each of the pollutants, we've measured in each of the communities, we measured criteria pollutants essentially continuously over the course of the study, and some other speciated PM components of interest as well. I'll be focusing mostly on the near roadway pollutant effects. Early on, we geocoded all the homes and schools of children in the participating in the studies, and then we assigned traffic metrics to those locations using some of the same tools that John described. I'll be talking today largely about distance to a freeway or major road, which everybody intuitively understands what it means. I'll be talking about a standard line source dispersion model that's commonly used to estimate traffic-related pollutant exposures. And finally, we've done dense measurements of NOx and size fractionated PM and PM composition in a sample of homes in each community. We've used those to develop prediction models based on traffic and land use. So here's the key figure from an early paper we published looking at asthma and its relationship to traffic, and you can see there's about a 50% increased risk of lifetime asthma at study entry among children who live within 75 meters of a major road compared to children who live 300 meters away, with a fairly nice dose-response relationship. We picked those categories of distance as our exposure metrics based on work that actually has been done by colleagues of ours at UCLA in Los Angeles, looking at particle number and carbon black that are biologically plausibly related to asthma pathogenesis, and you can see there's this steep increase as you get to a major roadway, and then a very dramatic decline back almost to baseline by about 300 meters. And this pattern follows quite closely the health effects that we've seen. We've gone on, we've looked at incident asthma over the course of follow-up, new onset asthma based on exposures at the home and school at study entry. We've seen a larger effect based on dispersion modeled estimates of near roadway traffic-related pollution, and we've seen about a 50% increase in the risk of new onset asthma across an IQR of near roadway exposure. We see almost as large effect of exposures at school, even though children spend less time at school, perhaps because they're more active at school than they are at home. We've looked at a whole variety of covariates, a fairly comprehensive list of covariates, and we haven't found that any of these co-exposures or characteristics of children confound the relationships that we see. Of course, in drawing inference and developing policy, the potential for residual confounding is always an issue, and I think an important feature of this story is the biological plausibility. I think over the last 10 to 15 years that these studies that we and others have done have been developing, there's very strong toxicologic evidence that's accumulated that oxidative stress and inflammation are fundamental to the pathogenesis of asthma, and ultrafine particles that John referred to especially have strong oxidant properties and generate inflammatory responses. And I think there's really quite good biological rationale that these associations are plausible. And finally, this is on the theme of PAHs, a figure from a study that my colleague Tauhid Salam did a few years ago. And Tauhid looked at two genes in the metabolism of PAHs that have functional variants. And this epoxide hydrolase has a couple of variants that define a phenotype that more rapidly metabolizes PAH along this pathway into a pathway where it will increase oxidant stress-mediated tissue damage, and GSTP1, the GST family, detoxifies these metabolites. So these are two key genes that are involved in the metabolism of PAHs, of these near roadway exposures, and Tauhid had some very clear hypotheses setting out as to the sort of increased risk that he would see associated with traffic pollution exposure. And I'll go quickly through this. The high the high activity EPHX1 phenotype was associated with about a 50% increase in the risk of lifetime asthma at study entry. There was an interaction, there was a gene-gene interaction between EPHX1 phenotype and this glutathione transferase functional allele with a fourfold increase risk for sort of the high-risk population, and a very strong and significant interaction. So it then went on and looked at the interaction between residential distance from a major road and EPH, the epoxy hydrolase phenotype, and there was a threefold increased risk, also a significant interaction. And finally, the bottom line was that children who live far from a major road and had low-risk genetic variants compared to children who lived within 75 meters of a major road and had the high-risk variants. There was a three-way interaction, gene-gene by traffic proximity, and that was significant, and the high-risk group had a ninefold increased risk of asthma. So plausible biological pathways, risks as large as anything that you see in environmental epidemiology. And I think the take-home lesson from this is that this pattern of genetic susceptibility that's been seen in the Children's Health Study is really hard to explain based on confounding. I think these really are causal relationships, and they're results that are consistent with a whole body of literature that's emerging from the U.S. and Europe, showing that, in particular in prospective, sort of the stronger prospective studies, that living near busy roads and freeways is a risk factor for asthma. So that's the case, that these are causal relationships, and I think it's fundamental to being able to do the sort of risk assessment and regulation that we think's called for next. So Risk assessment generally has evaluated regional pollution on large scales across the U.S., across California. There are people in this building that are much more expert in risk assessment than I am. But we thought we could add value to this type of risk assessment by looking at the burden of local traffic proximity pollutants. And in addition, we started out. We wanted to look at the estimates of the burden of disease associated with the joint exposures to regional and near roadway pollution in high-impact locations. Rather than spreading the risk out over the entire state, we wanted to look at some communities where there was a lot of pollution, and we could tell local policymakers what the impact was in their communities. And finally, we wanted to add some estimates of the cost to this. This framework is built on an insight that Nino Kunzli had when he was working with us a few years ago, where he pointed out that if you look at the proportion of all children with asthma that could be attributed to near roadway exposure, this causal relationship that I've been talking about, then the exacerbations in that group caused by exposure to the family cat, by an upper respiratory tract infection, by dust mites, all of that can be attributed to near roadway pollution, because this is what caused the asthma, and that has large implications for risk assessment and for the sort of relative impact of near roadway pollution and regional pollution on asthma exacerbation. So we took that framework, and the next paper that we wrote looked at the impact of near roadway pollution and regional pollution in Long Beach and Riverside. We attributed roughly 9% of all the cases of childhood asthma to near roadway proximity exposure, and about 6% of the cases in Riverside to CHS communities. This is standard risk assessment, looking at the whole population. It's not actual epidemiology. And then we looked at a variety of exacerbations based on that you see, asthma exacerbations you see here, based both on our work and on work in the literature. And we saw, depending on the outcome, we saw larger or smaller contributions from regional or near roadway pollution for reasons that I won't go into here. But the end result was that we could explain almost over half of all asthmatic bronchitis based on the combination of near roadway and regional pollution exposure. About 10% of emergency room visits and 10%, a little over 10% of clinical visits for asthma, and almost 20% of hospitalizations in these two communities. So these are much larger effects than you see with the sort of usual approach to risk assessment. And then we found a bright young economist who, and we recruited her to look at the economic cost of these, and she estimated that about $18 million yearly could be attributable just in these two communities to the effect of the combined pollution exposures. It's a nice integrative measure, I think. It sort of convinced me that this economic approach has some potential to it because you can integrate across various outcomes that are hard to compare otherwise, and about half of this 18 million could be attributed to the near roadway pollution. So the sort of traditional risk assessment probably underestimates by about half the cost of these pollution. Just to put it in context, this amounts to about 6% of the health and welfare budget for all of Riverside County, not just the city. About a fifth of the Department of Health and Human Services budget for Long Beach. It would be a major whack out of the public budget if that's where the costs were borne. But of course, these costs are borne largely by the children and the families who have asthma, and the first author on this estimated that this accounts for about 7 to 8% of the average household income in these communities, and the economists say that 5% is a sustainable sort of maximum threshold for healthcare expenditures for the entire family, not just for the single child. So this was a lot of fun. We've gone on now. We've looked at the number of asthma cases attributable to traffic proximity in the entire county. Somewhat to my surprise, the attributable proportion, the proportion of asthma attributable to near roadway pollution is as large in the entire county as it was in these two, what I thought were high traffic communities. About 8 to 12% of all childhood asthma, depending on the concentration response function that you use, and somewhere in the order of 20 to 30,000 cases. So a big impact. We're still working through the costs of it, but it looks like it's going to be somewhere in the ballpark of $400 million a year in the county, about half of which comes from the near roadway pollution effect. So what to do about it? You know, we aren't policy people, but we've had some invitations to work with the planning department, both with the city and the county in Los Angeles, and we've developed sort of this simple statement here that there's really good science that would justify regulating exposures within 500 feet of a major roadway. And over the last few years, you know, either because or in spite of the work that we've been doing, there have been a couple of independent efforts or a couple of independent regulations that I think are moving in the right direction. Fran Pavley was the author of a bill in the legislature here in California that prohibited school construction within 500 feet of a freeway, and the director of the Community Development Corporation in Los Angeles County controls a large pot of money for low-income development of low-income housing. Took, I think, a very courageous stand that the agency wasn't going to fund the construction of any low-income subsidized housing within 500 feet of a freeway. I say it was courageous because this has brought the ire of the development industry, which is quite strong in Los Angeles, down on her. This is just a menu of potential solutions that John and I came up with that I won't go into in detail. We're going to present it to the legislative forum that Amy's organized for this afternoon. And you can see sort of some things that we thought might be might be promising for policy development. I've talked about this: improved public transportation infrastructure, further reduction in diesel emissions, potentially requiring Caltrans to assess near roadway health impacts of new infrastructure construction, and finally, some consideration of near roadway public health impacts in the greenhouse gas reduction planning. As a lot of you know, there's California has a landmark legislation that mandates the reduction of greenhouse gases, and all the local planning agencies in the state are scrambling, trying to figure out how to come up with plans that will do that. I think there are clear health co-benefits from regional pollution reduction. That's quite well recognized. But there are, depending on how greenhouse gas reduction planning is implemented, I think there are some potential health trade-offs around near roadway pollutant exposure, because a lot of the plans are to increase residential density along heavy corridors with public transportation, and that, of course, will increase the population-weighted exposure to these near roadway pollutants. I think that there are some opportunities for win-win strategies to be developed that will reduce greenhouse gases, regional pollution, and near roadway exposure. I mean, just one example that you could think of would be in the mixture of options for reducing greenhouse gases to prioritize zero-emission vehicles powered by low-carbon electricity. I'm just going to finish up with, in the last couple of minutes that I have, with just some examples of some other air pollution cumulative respiratory impacts. And Roz yesterday started out talking about co-exposure additive effects. That's what I've been showing you so far today, additive effects of near roadway and regional pollution. But there are also synergistic effects, and I'll give you a few examples. I've already talked about one between near roadway exposure and genetics, these huge increased risks that you see in genetically susceptible population, and then some others. So here's a paper from the CHS from a few years ago where we compared we looked at the joint exposures to in utero exposure to maternal smoking and then subsequent child smoking on the incidence of asthma during follow-up. And the effect of exposure to maternal smoking by itself was quite low. It was null in the absence of personal smoking. The effect of personal smoking by itself in the absence of previous in utero exposure to maternal smoking was modest and not significant, but the two of these together gave a really very large eightfold increased risk. We didn't see this for air pollution, but it was motivated by a very nice study that Rachel Miller at the Columbia Children's Center did a few years previously, where she looked at the effect of total PAH exposure during gestation in a birth cohort, and its relationship to the probability of symptoms strongly suggesting asthma at 2 years of age. And she showed that in the children who had secondhand smoke exposure in the home, you had this very strong relationship between PAH exposure and subsequent asthma, and there was really nothing going on in the group that had no secondhand smoke exposure. So not just additive, but strong synergistic effects of co-pollutant exposures. There was a fair amount of discussion yesterday and this morning about the effect of psychosocial stressors and social stressors on a variety of outcomes. We partly motivated by a paper that Roz Wright had published just about the time our most recent cohort was recruited. We asked each of the mothers about their perceived stress at the time that children were recruited into the study as a marker for household stress that might affect the child, because the children were too young to assess stress in. And we found that this household stress was associated with incident wheeze on follow-up. We went on, we got excited about this, and we looked at a variety of social stressors based on information from the school, from the census tract, and the community. And we saw that new onset asthma during follow-up was associated with Title I attendance at a Title I school, which is a marker for social deprivation, and with community crime rates. So this was sort of an interesting package that we thought, as has been suggested, might be related to psychosocial stress. We didn't see an association between new onset asthma and the household stress measure, which is sort of what we thought we might see. But when we looked at the interaction between stress and air pollution, we saw quite strong synergistic effects. And here, I'll interpret this for you. This is the relative risk of asthma associated with an interquartile range exposure to near roadway modeled air pollution, and it's expressed by quartiles of household stress. And you can see that there's not much effect of near roadway pollution in the low stress households, but this really marches up in a fairly monotonic fashion across quartiles of household stress. So again, synergistic, not just additive effects. We see similar effects on lung function. This is traffic modeled NOx at home and school. This is the main effect, percent deficit of sort of 1 to 2%. But if you stratify by parental stress, you see this is FVC, sort of a marker for total lung volume. You don't see much going on in the low stress families, but in just dividing at the medium, the high stress families, you see a 3 to 4% deficit. So again, so very strong interactions. I'm going to just finish up by acknowledging a whole host of co-investigators that I've been privileged to work with over the last 15 years, and our sponsors, in particular the National Institute for Environmental Health Sciences, the South Coast Air Quality Management District, and the Environmental Protection Agency.